everybody. Thanks so much for coming on Monday, which I know is a very busy day at the Assembly, so it's great that you could make time to be here. But you have come to what will undoubtedly, when you think about it at the end of the week, be the most important session that you've attended at the World Health Assembly of all of the sessions that you will have been to. My name is Richard Horton from the Lancet, and today we're going to discuss and reflect on the findings of the Global Burden of Disease 2021, which was published just a few weeks ago on May the 16th. Our partnership with the Global Burden of Disease goes back to 1997. Elsewhere, I've described the GBD as the Human Genome Project of global health, by which I mean it's an ambitious, even audacious project to measure, monitor, and map the health of every human being on the planet. The 2021 GBD is important because it's one of the very first studies, perhaps the first study, to comprehensively evaluate the first 2 years of the COVID-19 pandemic. And while it showed how fragile progress in global health can be because of the unprecedented reversals that it has documented, it also raised important new questions. The GBD has revealed intriguing paradoxes and has discovered what it rather poetically calls in one of the papers a new global health landscape now that COVID-19 has receded. Let me describe the order of the event. We're going to hear first from Professor Emmanuelle Agakidou, who's the co-founder of the Institute for Health Metrics and Evaluation and has been working on the GBD since 1994. And we will then have a panel with responses from Haidong Wong, who is the head of monitoring, forecasting and inequalities in the Department of Data Analytics and Delivery for Impact at WHO, and Calypso Chalkidou, who is currently, for a few more weeks, the head of Department of Health Finance at the Global Fund, but is about to become Director of Health Financing at the World Health Organization. We will then have a question and answer session with you and those online, and Siri Moon, the Director of the Global Health Center here at the Geneva Graduate Institute, will say a few closing remarks. So let's start, and please give a big warm welcome for Professor Emmanuelle Agakidou.
Thank you very much, Richard, and thank you, everybody. It is a pleasure to be here today. I am not sure who is more happy that the GBD 2021 is over, us at IHME or the Lancet. I think it's a close call, but nonetheless, it is a joyous event, and I would like to think it's the most important you're going to attend this week, but the one thing I can guarantee is that it will be the one where you will see the most graphs and numbers of the week, undoubtedly. So let me get started. So for those of you not familiar with the Global Burden of Disease Project, which we call the GBD, we refer to it as a rules-based synthesis of global health data. And so what that means is we take all the information available on what makes people sick and what kills them, and we put it together in a way that is internally consistent and coherent. And we have a large set of rules that keep us honest and make us count well. And I'm not going to go into those rules, but if you are interested, I would be very happy to share. I wanted to start first by acknowledging that we would not be here were it not for the vision of Dr. Richard Horton, the editor of The Lancet, who, in his own audacious move back in 1997, published 4 papers, which was never done before, is my understanding in the Lancet, on one study. And that was the GBD 1990. You can see that over time, this is what it looks like today. The Lancet has gotten a little bit more colorful and a little bit better in the design. But nonetheless, in the issue of 16 May, which you all have here for you today, we published the 7 capstones for the Global Burden of Disease 2021. And I wanted to thank Richard for providing a platform to share, but also to rigorously peer review this work. Any of you who have published in the Lancet may be familiar with the process of peer review and how rigorous it is. Let me reassure you that when you submit the global burden of disease, it is at a whole different level. But thank you very much, Richard. So how do we do this? I wanted to start by mentioning that a few of us sitting in Seattle cannot possibly produce a study the magnitude of the global burden of disease on our own. So we do it with a massive network of collaborators. It's currently at over 12,000 collaborators around the world. The map shows roughly the distribution by numbers, and you can see that we have some parts of the world that are very largely represented in our network of collaborators, and other parts of the world that are in fainter shades of green. If you are from one of those locations and would like to contribute to the GBD, please do sign up to be a collaborator. Our collaborators are involved in all aspects of the work, ranging from data and providing us the invaluable inputs into the GBD, to reviewing our results, to considering all the interpretations of the findings, and most importantly, to taking our findings and translating them into meaningful policies in their countries. So this is health statistics humor. So this is a few numbers for the global burden of disease to give you a sense of how massive it is. On the left-hand side, you can see the number of diseases and sequelae that we estimate, along with what we call impairments, which are more envelope conditions, risk factors, and etiologies, which are specific causes that result in some of these diseases. We are currently estimating for 1,075 locations. If you're confused by that, we have 204 countries, but 21 of them we go to the subnational level, and so it comes up to over 1,000 locations that we produce estimates for. We have 25 age groups, and every iteration of the GBD produces a consistent time series from 1990. So every time we release, it supersedes every previous release, so please do not use any of our previous numbers. The new ones are always better, and we produce everything to make it consistent. On the right-hand side, you can see just how massive in terms of computation and infrastructure the undertaking is. So one summary level of all the estimates is 14 terabytes, just to give you an idea of the sheer magnitude of the computational power. If you're interested in exploring the results, we make them all publicly available, and this is our most used tool. It's called GBD Compare, and all of the estimates for diseases and risk factors are available there. We have been told many times that is not very intuitive. So I'm very happy to announce that as of last week, if you go to the top right-hand corner of GBD Compare under Help, there's a very nice tutorial, self-guided training that will explain all the various views and how to extract any information you may want from the GBD. So the main thing we rely on for the GBD is data. I wanted to also acknowledge my colleague, Kara Estep, who is here. She's the Director of Research Operations at IHME. And if I had to point to one person who is responsible for producing the GBD and making sure we do not fail, that would be Kara. I will direct any data questions to her if you have any. I wanted to highlight not just the sheer magnitude of the number of data sources that go into the GBD, which are over 300,000, but also the multiple types of data that we use. So we use anything from legislative data to administrative data to reports, of course, a lot of household surveys, vital registration, and financial reports are among the data types. All of our data can be found in an online data library that we call the Global Health Data Exchange. And any of you that may be graduate students or teach students, it's a great resource for finding any data related to any health condition. Since the entire GBD is indexed there, we think we have a good proportion of the world's data, at least the ones that are publicly available. Of course, there's a lot of variation on the number of data that we have available across geographies. So in this map, the locations that are colored in red represent locations that are relatively data poor, and the locations in shades of blue are locations where we have a lot of data. If you cannot read the legend, the locations with shades of red and orange have fewer than 1,000 data sources for the entire GBD. So keeping in mind how many diseases and risk factors and years and locations we produce estimates for, these are very data poor locations. And so additional data will improve the GBD significantly. The locations on the higher end of the data landscape have over a couple of thousand of data sources for that one location. So with that in mind, it was very hard to pick across billions of results 10 slides to show, but I will show you a few of the results that to me are the most striking from the GBD 2021 and also have some pretty profound implications for future thinking of how we should be organizing health systems, but also other social sectors as well. So I'm going to start with fertility because it is a very highly discussed topic these days. And on this graph, the horizontal axis on the x-axis is year, when we're starting at 1950 and going all the way to 2100. So we're showing projections to the end of the century. And on the y-axis is the number of countries. The blue line represents the total fertility rate. And the line that I think is showing up as red represents what we call the negative rate of natural increase, which essentially is the time at which the number of deaths in a country exceeds the number of births. So what the dashed line in the middle is the year 2022. So what you can see is that already today, more than half the countries are at below replacement fertility level. That would be 2.1 for replacement fertility. And it is projected that almost all countries by the end of the century will be at below fertility level. The red line, so the time at which the number of deaths in a country in a given year exceeds the number of births, follows the trend fairly closely. We're now at the trajectory where it's fairly parallel and about 20 to 25 years behind. So this is going to have pretty profound implications for the age structure of populations around the world. We're already in a setting where the countries with the highest fertility above replacement are predominantly in sub-Saharan Africa, and we're seeing even countries in sub-Saharan Africa reaching below replacement fertility by the end of the century. Looking at births in a different view, this graph shows where in the world the births are happening. And the regions here are grouped by the World Bank income groupings, where the low-income countries are in red in the bottom, and then we have lower middle income, upper middle income, and high-income countries. And again, the x-axis starts in the year 1950 and goes to the year 2100. And what this graph shows a lot of things, but one of the things that it shows very, very prominently is that over 30% of the births by the end of the century are going to be happening in locations that are classified as low income by the World Bank. And the proportion of births happening in the upper income and upper middle income countries is going to be reduced to about 20%. Again, this finding has pretty significant implications for where these babies are born, what they will need to do well and thrive. And also, you can imagine implications on migration and other trends that might happen around the world. So shifting gears a little bit to look at life expectancy. This graph, again, is showing you starting in 1950. The end year for this graph is 2021. On the left-hand panel, we have females. On the right-hand panel, we have males. And the different lines represent different world regions, with the global being the dashed black line in the middle. So, of course, there are a lot of interesting trends in life expectancy, and one of the most obvious ones is the dip in all regions for females and males right at the end, which represents the impact of COVID-19. But looking at it from a different lens, another thing that is striking is that the gaps in life expectancy across world regions are not narrowing at a very fast pace. So a lot of the inequalities that we see even as far back as 1950, do not shift significantly over the 70-year period of this graph. And even though both males and females are making significant progress, if you look at the height of life expectancy for sub-Saharan African men in 2021, it is not that much higher from where women were back in 1950. So there's still a lot more progress that can be done to improve life expectancy and mortality rates among men, as well as reduce the inequalities and disparities across regions. Okay. To shift to a very different kind of graph, this graph takes that change we saw in life expectancy over the last 30 years or so and decomposes it into what has contributed to that change. And here's where I wish I had a laser pointer, but this line, if you can vaguely see my pointer, is 0. So anything towards me from that line represents something that made life expectancy go down, and anything to the right-hand side of that line represents improvements in health systems, lifestyle that led to increases in life expectancy. The regions of the world are ranked by the overall increase in life expectancy over the time period between 1990 and 2021. And so we can see that the region with the most progress was Southeast Asia, East Asia, and Oceania, which overall gained 8.3 years of life expectancy. And the region with the least amount of progress in this time frame was Central Europe, Eastern Europe, and Central Asia, with only a 2.1 years of increase over a 30-year period in life expectancy. The causes on the left, so the ones that are causing life expectancy to go down, are predominantly COVID-related, so either COVID-19 directly or other things related to the pandemic. And on the right-hand side, most of the causes that have the biggest proportion of explaining the improvement have to do with communicable diseases. So there is a lot of progress that has been made on diarrhea, pneumonia, neonatal mortality, and other communicable diseases. And we're seeing some progress on some chronic conditions like ischemic heart disease as well, but a lot less of a contribution of NCDs to the progress compared to communicable diseases. And generally, just glancing at this graph, it is pretty striking how much of a reversal COVID-19 caused to the background trends of improvements in life expectancy. This is one of our favorite ways of representing a lot of information in one graph. It's what we call a tree map, and it shows all the major causes of DALY, so shifting from mortality to disease burden, so things that both kill you and make you sick. This graph shows for both sexes and all ages just a very high-level view of the major causes of disease burden in the year 2021. We have a new cause on the top right-hand corner, COVID-19. It's hard to miss. It is massive. Depending on how you count and whether you look at deaths or DALYs, it's either number 1 or number 2 in 2021. So undoubtedly a massive shock to health systems and life expectancy. The bottom right-hand side in gray that says other COVID, eventually through various rounds of GBD will be reattributed to other causes. It's still pandemic related, but not necessarily clear where those deaths should go. But in addition to those glaring boxes related to COVID, we can still see, and despite the progress on neonatal mortality, we still see a massive box related to neonatal causes, both mortality and morbidity. And on the right-hand side in blue, we see all the NCDs, and some of the bigger ones, like ischemic heart disease and stroke, are things you might expect. But we also see causes that only lead to disability, so they do not kill you, but they make you sick, like back pain showing up at such a summary view like this, as well as oral diseases and several mental health disorders. So the landscape of current health needs of population is a very interesting mix of infectious diseases, injuries in green, and then a lot of different NCDs, which shows you just how complicated a job health systems have to do to handle the current challenges of their populations, which are aging, and they're aging with diseases that make them sick, as well as shocks like COVID-19 that lead to massive numbers of deaths. Looking at what we might be able to do, or some of the things that lead to these causes, is a view of the risk factors that contribute to the global burden of disease study. This is only one summary slide of the results on risk factors, and it shows the percent of total DALYs that are attributable to these categories of risk factors. So in other words, this graph answers the question, how much would the burden of disease be reduced if we removed all burden attributable to one of these risk factors? So leading the chart is malnutrition. We can see air pollution is also a very big cause of disease burden, and one that in many ways one could claim is preventable and avoidable. And then we get to the non-communicable disease risk factors, which up there on the graph we have high blood pressure, all the tobacco-related ones, diet, fasting plasma glucose, and BMI, both of which lead to a lot of diabetes, among other conditions, and then cholesterol. So you can again see here that the profile of risk factors ranges from things that cause communicable diseases, respiratory diseases, but also a lot of NCDs. This is almost a graph of hope, because for a lot of these risk factors, there are things we can do, there are known interventions, there are ways to avert the burden. And so the encouraging part is that if we intervene on these risk factors, we can actually change the future of the profile of the burden of disease for global populations. So looking at a little bit of forecasting, because part of the session for today was looking at the future. So here I'm showing you a graph that I showed you a little bit earlier to 2021, except here we're projecting if business as usual continues. So if the world goes along the trends that we have, assuming that COVID-19 was just a blip and then we'll revert back to normal, this is what would happen to life expectancy for females, again on the left, and males on the right over the next 30 years. And again, you can see that the slope of increase in life expectancy is slowing down pretty much everywhere. So even though life expectancy is not projected to decline anywhere, the rate of increase has slowed down in a lot of regions. The gap between regions is projected to be narrower in 2050 than it was in 1990, but there's still a pretty significant gap, with sub-Saharan Africa being the region in red, which shows the lowest life expectancy, making some progress. But as I mentioned earlier, there are a lot of things we can do to accelerate the pace of progress and also make sure that the majority of the children in the world that will be born in this region will have better outcomes later in life. So this graph is looking okay. It could look a lot better with intervention and early action to improve outcomes in the next 30 years. Okay. This graph has a lot going on. And we love graphs at IHME, but let me quickly tell you what you should focus on. So the top line is counts, so it's numbers. The bottom row is rates. So if you prefer to look at numbers, look at the top. If you prefer to look at rates, look at the bottom. The first column is global, and then it goes through the world regions, with sub-Saharan Africa being all the way on the right. Green is injuries, blue is NCDs, and orange is infectious diseases. So it's at a glance, between 1990 and 2050, what does the profile look at a big level between injuries, non-communicable diseases, and infectious diseases, and other causes that go into the red category, like maternal, neonatal. So what we can see very clearly is the one region that in 2050 still has a pretty significant shading of red is sub-Saharan Africa. There's progress there, but there's going to still be 30 years from now a considerable amount of burden in sub-Saharan Africa from infectious diseases, maternal causes, neonatal causes. So again, there is a lot that intervention can do. South Asia is another region where the rate of progress for group 1 diseases, infectious diseases, is improving, but still will be significant in 2050. The majority of burden in most regions by 2050 is blue. That's all the NCDs, and it's growing at pretty frightening paces over time. Again, the graph on risk factors that I showed a little while ago shows that a lot of the burden from NCDs is attributable to risk factors that we can intervene on and we can potentially avert. So even though this looks bleak, it's up to us to intervene and change it and make it better for the future. I only have 2 more things to show, and then hopefully we'll have a lot of discussion. Another way to look at what will happen to the burden of disease as people get older is they live longer years, there's more time to experience disability. So this graph shows the proportion of total burden that is due to disability. This is for the year 2022, and the blue countries that are shaded in blue is generally above 50%. Countries that are shaded in red and orange is below 20%. And I'm not going to give you a quiz as to which country is what color right now, but just visually look at this. And then the next map I'm going to show you is the same thing for 2050. So very quickly, this is 2050. So we see a lot less red, a lot more yellow. I'm going to flip back and forth one time. So this is 2022, and this is 2050. And what I wanted to emphasize is that in 30 years, pretty much a third of the burden everywhere in the world, and all the way up to 2/3 of the burden, will be for conditions that are causing us to live with disability, not just kill us. So as populations are aging, as people are moving to that phase of life, we also need to make sure that health systems are prepared to handle the increasing burden due to disability as people live longer and suffer from other conditions that are growing at a faster pace than they have to date. And I'm going to end with a message of hope. So we ran some numbers to say, okay, how much of the burden would go away if we intervened in some of the behavioral and metabolic risk factors that I showed you being very prominent in the risk factor profile. So this is running a scenario through our forecasting pipeline where we say, okay, the world will take these risks seriously and we're going to do something about behavioral and metabolic risk factors. And the graph shows you the proportion of burden that would go away by 2050. So within the next 30 years, the shades of red represent the orange and red is greater than 10 or greater than 20% decrease. So we do have the potential with known interventions today to intervene and change the course of burden of disease, even within the next 3 decades. And so I welcome the discussion with all of you as to how we can take what I showed you today and make it not come true and improve the health and well-being of people around the world. Thank you very much.
Brilliant. I think you take a seat. Let me invite up Calypso and Heidel. So what we thought we would do What we thought we would do is invite Haidong and Calypso to give a few minutes of reflections on GBD 2021, and then we'll go into some questions. So, Calypso, shall we start with you?
Yes, thank you. Okay, so in fact, thank you very much. I was just saying, I've been reading your publications in your name, and you might have noticed that our names have the same ending. So we both come from Greece, and we're tribally linked, perhaps. So that's wonderful to meet you. And thank you very much. I really found your maps and graphs of hope to be really important, I think. Thank you for allowing us to understand where we are today and where we've come from, but also to have a sort of a sneak peek into the future and then change it if we so decide. I think that's really empowering, and that's the purpose of data, I think, so that's fantastic. I have a couple of points to make. One is on equity and distribution of what we're seeing and how granular your data can get to show us both trends but also the current situation and of course, what the future might look like. And I know that you're doing some of this work. And I work for the Global Fund for now, and I just wanted to say something. I mean, HIV, is TB and malaria, the three major diseases that the Global Fund invests in, and I saw in the Sub-Saharan Africa bar chart the half a year improvement in life expectancy. And I think that number is actually masks a lot of stuff under it. And I wanted just to cite, it's published, a study by Marcus Hacker, who unfortunately passed away suddenly last year. And what he did was looking at panel data. He looked at what the contribution of TB, HIV, and malaria was over the years. In fact, he looked at 2002, since the Global Fund was set up, in 2019, what the contribution of reducing mortality from those three diseases was to reducing global inequality in life expectancy. So what he found was that global inequality in life expectancy reduced by about a third during this period, 2002 to 2019. And about half of that was thanks to reducing mortality from TB, HIV, and malaria. But what I find even more important, I think, is that he also found that about 15 countries in Sub-Saharan Africa, accounting for about 5% of the population on the planet, were also responsible for 40% of the global decline in mortality. And 2/3 of that was, again, TB, HIV, and malaria. It was mostly these three infectious diseases. So I think in that sense, the Global Fund must have been one of the most important interventions for reducing inequalities in life expectancy. And this is what this data can show us, I think, the past and of course, going into the future. And the second point I wanted to make has to do with money. I guess I head up the health finance team at the Global Fund, and the power of bringing together financing information with this burden of disease information. And I know IHME have a fantastic database of donor overseas external funding flows into countries. But less so perhaps when it comes to domestic financing. And I think it would be absolutely wonderful, and in fact it would be critical if we want really to intervene and change the course of the future through tackling those risk factors you flagged, to have a better understanding, all of us, the country planners, the citizens of countries' parliaments, scientists, researchers, of exactly what is being spent on things at country level. And we need this information to talk a little bit more in a more informed way about value for money, for instance, and efficiencies at a time when there's little money going around, new money. We need this information to be able to have a conversation about country ownership and sustainability, as potentially external development assistance may flatline or even shift or be reduced. And also to hold ourselves to account and hold the policymakers to account, the leaders of countries, rich and poor, to account. Where is the money going, and what is it achieving? And I think it's really problematic currently. We're actually flying blind when it comes to to funding flows at domestic level. And I think that's really a huge missing piece. But thank you very much.
Thank you. Just to follow up on what you said, you come from the tribe of Greece, and I actually came from the tribe of IHME. So I say I know how much effort this collection of research actually reflects the efforts by both the teams at IHME and its impressive 10K strong collaborator I mandated. Because I remember in January 2019, when my last saw Richard in Seattle, we were talking about wrapping up GPT 2019 and what's the future holds for GPT, which was GPT 2020, which we didn't get published. Now we're skipping to GPT 2021. And fast forward 2 years, I joined WHO, coordinating WHO's effort in generating a comparable set of estimates, which we call the Global Health Estimate, which is also Chris Murray's legacy for WHO. So as Em mentioned, the GPT represents the most comprehensive and internally consistent estimates, not only on mortality, but also morbidity, risk factors, and by extension, health financing as well. And that's what the country needs for better decision-making. And, we need better analytics, we need better and actionable data. And that's what WHO is doing, especially since General Program Work 13, for example, we have 46 outcome indicators covering 3 areas: universal health coverage, promoting better, healthier lives, and health emergency protection as well. And on top of that, triple billion targets. And at the very top of the impact measurement for GPW 13 is healthy life expectancy. Again, a long-lasting metric that summarizing both mortality and morbidity at the population level. So, that's the reason why, WHO and as far as I know, many of the technical programs, why we value the partnership with GPT. And I know that many technical programs, including MR or, the project looking at climate change and health are already working with GPT closely, and many programs plan to work with GPT in the next couple of years. And we see the power of data and how useful such information can be useful for both the technical program and the headquarters, and also for our member states as well. And I'm glad Em mentioned the forecasting work. I was actually for a few months the team lead for forecasting as well, and worked on the fertility forecasting. And that's exactly what we need. We not only need to know what happened in the past, what's happening now, and we need to know what's most likely is going to happen, and what are the alternative scenarios. And this is in conversation with many colleagues from the Ministry of Health at the country level. When we present something, the question always comes after that is, so what? What can we do? What are our options? If we do something, what change can it bring? Like, how much increase in life expectancy are we talking about? And the future health scenario is exactly useful for that purpose. And we're looking forward to working with GBD, IHME closely to provide the information to the country so they can actually utilize that as well. The last thing I want to mention is, to make real impact at the country level, the country needs to be involved and to own essentially the entire data value chain, meaning that, data always collected in the country, and we need to work with the country in producing the estimates, and that way it empowers them to use the estimates as well. So it becomes a very healthy cycle. And this is something, we certainly are looking forward to working with other partners like IHME and other global philanthropies to improve that as well. So it's really great collection work, and congratulations.
Well done, thanks. Give them a round of applause, please. The questions aren't appearing on my iPad, so maybe we could just have a look at that, because we want to get some questions from the audience. But I want to kick off first, and I just have a few little points for you, if I may, because when you read this hundreds and hundreds of pages, there are some fascinating little nuggets that jump out. We think that COVID-19 was a terrible global disaster. But there were some, how can I put it, maybe anomalies. So for 20 countries, they experienced during 2020 and 2021 a negative excess mortality. For 32 countries, they saw life expectancy not decrease, but increase. So it wasn't uniform, was it, the impact of the pandemic?
It was absolutely not uniform, and thank you for providing me an opportunity to speak about it a little bit more. Actually, one of the things, in addition to what you just mentioned, Richard, one of the most surprising things to me was that child mortality progress kept going throughout the pandemic. And early on in the pandemic, there was a massive amount of concern that the gains we had seen in child mortality were going to be reversed. And we did not see that, which is hugely encouraging. And we did see that several countries fared a lot better than others. What I will say is that I think before we say the definitive word on that, we should probably wait and see what happened in 2022 and 2023, because what we're seeing now in the data that are coming in is that some countries that fared decently in the early stages of the pandemic did not do so well in the follow-on years. Though I remain fairly confident that for child mortality, the progress kept up even in the later years.
Very interesting. Question to all three of you, and Haidong, you perhaps alluded to this the most in your response. We have a lot of data, we have a lot of estimates here. How can we turn these into actionable guidance for countries? I mean, let's start with you, Haidong, because this is your, at WHO, as a member state organization, this is your day job, isn't it? To turn data into actionable guidance. So tell us how we go about doing that better.
Yeah, and thanks, Richard, for the question. I think one of the challenges, I mean, I have limited experience at the WHO interacting with member states, but still, I have seen many times when we present, the global health estimates, or in some cases, working with partner institutions like GBD, to provide more comprehensive assessment, one of the most frequently asked questions is, why is this data different from our data? Meaning that the raw empirical data point collected by the country. So there is always a tension between how the global health estimates provided by whatever institution come about and why it's different from the data collected in the country. And oftentimes, the empirical data the country is talking about is included in the estimation process already. And then there's a tension of, why it's different from ours. And there's a question of trust, and I would say, empowering the countries, if they have the ownership, if they understand where the estimate is coming from, why it's different from the input empirical data or raw data, and they can actually use that to inform change. And we were actually just talking with Anne the other day regarding the use of the STEP survey provided by the countries through WHO to inform the smoking prevalence estimates for Vietnam, where there is no empirical data collected at the population level surveys for 5 years, but the country is going to review their policy, access policy, and they need more actionable data, more recent data. So this is the need for the country to have readily accessible analytical pipelines to update the data based on the information they want to use as input in a timely manner.
Very good, very good. Thank you. And for the Global Fund, Calypso, how do you turn the data that you have access to into actionable guidance for countries?
Well, we defer to the World Health Organization. No, I mean, we do actually defer to you, but at the same time, I think this is a wonderful resource. And, as at the stage of designing the grants, as we work with countries, there's increasingly an encouragement from our part to our counterparts in country to look at data. So I think perhaps one thing we could be doing is also more explicitly pointing to this database going forward. But Yeah, I think it is tricky to embed the whole culture of looking at data to inform questions about financing. I mean, we are ultimately a financing institution, and that's why I think having the data on money, on inputs and outputs, not that it's necessarily that simple, but at least having it there to see how exactly it pans out, both at the country level, but then also at the global level. We're having these discussions about global health institutions and their relative return. We've got a massive number of investment cases put forward by individual institutions. We know how much money the institutions have been receiving over the years. We could start coupling some of this with the impact. I think we do need to have a little bit of that discussion as we move forward, because as you showed us, the risk factors are changing and they're amenable to interventions, and the burden in the future looks different. So we need to do things a bit differently also, I guess.
Thank you. If you have any questions, if you're online, please type them into the chat box and they will come up on the iPad in front of me, and then I can put those questions to our panel. Now, Haidong, I don't want to put him in a difficult diplomatic situation since he works at WHO, but I can ask this of you. It's all very well saying, well, we come up with an estimate and then we go back to the countries and we arrive at this happy agreement or compromise with the country, but sometimes that doesn't happen. So India, to take one example, excess deaths 2020 to 21, the number in the GBD 2021 was 3,440,000. What's India's figure?
Haidong? It is different.
It is. I think for WHO, it's a similar number. Fun fact, I actually worked on that estimation process when I was at IHME. I mean, the best thing I think we can do in this kind of situation for researchers, both from an international organization and an academic institution, is present the empirical information that we have used, be transparent, and present the methodology to the country or, for that matter, any person concerned, and have a dialogue and a conversation. We might not be able to persuade anybody to be on our side, but at least we can arrive at a common understanding. And that applies to some of my interactions with some member states who had concerns or disagreement with other indicators, which we, in the end, we were able to, in some situations, were able to arrive at agreement. That's the best we can do.
But I think I'm right in saying that there is not a meeting of minds over the figure for India. And India, actually, in terms of the absolute number of COVID-related deaths, excess deaths, in 2020 to 21, it has the highest number of any country in the world, correct?
Yes.
Yeah. So how do we bridge this deficit in accountability? Because this is about accountability of countries, governments that are responsible for the health of their populations. They make promises, they make commitments, and then they need to be held accountable. And this is where surely WHO and IHME play such a critical role in being able to hold those governments accountable. Sure. How do we hold governments accountable?
So on our end, I guess with my experience at the WHO, the thing we can do as a division on data and analytics is exactly present the best methodology we come up with external partners and the technical advisory groups, and make sure everything we do is transparent, and we incorporate any suggestions or comments from the country or member states to make sure we do the best that we can based on the information that is available to us. That's the only way we can do.
I have to start by saying that I do not envy Haidong's position, in which I was about 20 years ago. So I did work at the World Health Organization, and I am delighted to be an academic now, because it offers you the freedom to actually look at the numbers and do the best science you have and not have to worry about all the constraints that member states impose on the global structure of the institutions such as WHO. I think our role in this is to be vocal about the numbers. We're very happy to share our data, our process, everything we do is up on the web. And we find that we do have conversations with countries. We actually just hosted 8 fellows from the India Council of Medical Research. They were at IHME for 2 months. We've been working with them over the last year. And we find that through dialogue and investing in training them on our way of analyzing data, slowly but surely, there is an increased understanding. I think the official government position is a lot more complicated to move, but if within the institutions, within the countries that are responsible for producing the evidence, we change the culture to be more transparent and more evidence-based, eventually we will see progress in that as well.
Very good. Let's come to the audience, please. If you could raise your hand and say who you are, and we'll get a microphone to you. I think we'll get a microphone to you. Yes. Gentleman here, please, with the white shirt and the waistcoat. A microphone is coming.
Hello,
Yeah, you're on.
my name's Bryn Williams, and I'm a former data person from the NHS, Cousins Thomas, now living in Geneva. So my question for you was, how much investment, not from the WHO, but from whatever bodies, is going into the countries that are delivering the data to you, to give them the infrastructure to be able to record the things we need to get to this sort of disaggregation of the data that will be in, I mean, the further you disaggregate, the greater the value the data will be. So are the international organizations helping the countries themselves, the individual countries, to build the infrastructure, just the simple thing of collecting data, let alone making sure the quality of that data is accurate?
That's great. Let's take a couple of questions at a time. Yes, at the very, very back in the top left-hand corner. Microphone is coming to you.
Thanks. I'm Dina. I'm a PhD researcher here at the Graduate Institute. I have sort of 2 questions, I guess, on accountability, which you mentioned already, but thinking about accountability for IHME and how we as a research community hold IHME accountable for the modeling and the data that they're putting out, in part because, as I saw from the previous iterations of this is a huge amount of work that goes in. It's also work that's funded by the Gates Foundation, and then alongside you have the Global Fund and the World Health Organization. So I'm kind of curious how the research community, how the peer review process works, given the sort of monopoly of data that IHME has and the inability of other researchers, both from a systemic perspective, but also in terms of resources to hold that data accountable. Secondly, on the question of modeling, I think modeling's super interesting, but we have the problem with modelling that we always have, and I think we saw this with the IHME modelling that was put out at the start of the COVID pandemic. The models you get out are only as good as the data that you put in, and it also becomes a question of what we measure and how we measure it, and I think reproductive replacement rates are really interesting for that because they speak to maintaining reproductive rates to sustain an economic system and not necessarily ask the question of what level of reproduction do people want or how do we deliver that. So 2 questions, one on monopoly of data and accountability, and the second on how do we ensure the robustness of the models that are being used, especially for these long time frame estimates.
That's great. Thank you very much indeed. Let's come to you first.
Thank you. Which one would you like me to take first?
Well, let's start with the holding IHME accountable.
I love to be held accountable. Ask me any question you want. I'll show you anything you want. I'm not sure what you mean by monopoly of data because we don't actually own any data and we don't collect data. So we are in a position where we collate data. We reach out proactively to countries. I mentioned our 12,000 network of collaborators. most of them sent us data sources or links to papers or anything, reports. Sometimes it's a Twitter feed like we used during COVID. And we incorporate all that data into the GBD, and then we put it up in the Global Health Data Exchange. There's a tool on our website called the GBD Data Source Tool, where you can look for every condition and you can see all the data that has been used. So I'm not quite sure what you mean by monopoly. We're Greek, so we have a very specific definition of the term monopoly. I would say we have democratized data, to use a different word, because everything we use, we do make publicly available, at least how you get it. We are bound by data use agreements in a very small proportion of the data we use, but for everything else, we let people know what we used and how we used it. And if you have any questions, I would be more than happy to answer them in more detail about any of the diseases that we model. The question on model performance and how do we make sure that models perform well is something that we look at very seriously. I was actually on the COVID-19 modeling team at the beginning of the pandemic. It was not an easy task, and you're absolutely right. The quality of the data influences the quality of the predictions, and it is part of the approach of the GBD. That's why we re-estimate everything every time a new iteration comes out, because as new data come out and new methods get developed, our estimation process gets better. It's the evolution of science. And it's part of what we embrace in the GBD. We think every iteration of the GBD is the best we've done, and we hope the next one will be even better. And so I think I would love to be wrong. I would love none of these forecasts to ever come true, because it's a pretty bleak picture. And if the power of forecasts is to motivate change and policy action, and we reverse some of these trends, then I would love to be wrong. I have to say that I looked at the original GBD papers, and some of the forecasts we made back in 1990 for 2020 were not that far off. So that's actually really sad. I was going to put a slide on that, but it was too depressing, so I kept it out. And again, like, forecasting is inherently an area of work where you can never be right and you can never be wrong. And we can go into the ethical discussion around it. But maybe I'll let some others talk.
No, that's great. Calypso Haidong, feel free to answer any of those questions that you wish, but I am very interested in this question of the adequacy of health information systems in countries, because it is true to say that the quality of estimates depends upon the quality of data that go into the estimates, as well as the quality of modeling. And I can remember over too many decades, I care to recall different initiatives to try and boost investments in CRVS, health information management systems, largely not achieving the goals that we set ourselves. What's the current state of affairs? Calypso Haidong, who'd like to go first?
Well, I mean, you can probably speak about the financing part of that support, but in terms of the technical support for countries, I totally agree with you. I think, well, we have better models, but even the best model, it just makes best use of available data. And the data always comes with different level of biases or different type of biases. So to have better estimates, better information, actionable data, we need to invest in health information system. And on the technical support side, WHO does provide a lot of technical assistance to the country when it's financed, of course. For example, we work with countries to establish or set up the district health information system, and our department do the World Health Surveys, and mostly funded by the country themselves. And we do annual or biannual assessment of the health information system at the country level, at least provide a biannual checkup of how well the health information system for each country performed, identify gaps, constraints, so that country can actually work on those. And I can't agree with you more. All the estimates are just based on empirical data, and if we don't have solid empirical data that is collected in a timely manner, we're not going to have solid estimates anyways.
Thanks. And on the financing side, Calypso?
I think there's way less investment going into financing data systems. I mean, the HIS2, I think, has a financing module, which I don't think has been used much at all. So yes, I think there's a big gap there, because most of the investment in data has been going towards epi data rather than financing data. That's a problem.
Very good. I have got some questions coming in here. So a question on the possibility of analysing data from zones of armed conflict. How easy is it to get data from zones of armed conflict? Are there data that you have access to understand the breakdown of disease and risk factors and excess mortality?
That is an area of huge interest and a massive data gap. Unfortunately, in the recent years, it has become more relevant to more populations around the world. We struggle to get data on countries that are undergoing conflict, on populations that get displaced as a result of conflicts or even natural disasters. As many data gaps as there are in routine health information systems, those get amplified massively in situations of conflict. We know that there are a lot of conditions that get exacerbated, a lot of violence that takes place that gets never counted, in addition to just the routine registration of vital events not happening. So it is an area of need of improvement. There are some UN agencies, UNHCR, the Red Cross, there are several agencies that try really hard. It is challenging to make data a priority when there are so many other competing concerns on the ground. But we welcome any data from those settings.
Thanks, Sam. A second question submitted online. How can predictive analytics and data forecasting be ethically balanced with patient privacy concerns to enhance healthcare outcomes without compromising personal data security? Is there a tension there? Maybe Haidong?
I think we're probably in a similar situation as IHME or GBD. Most of the analysis that we are conducting, aside from survey level information, mostly is at the aggregate level, at the population level, even though it might be subnational, but it's still population level. So we certainly, for example, at the WHO right now, recently we have passed the data protection policy, and we're going to have a data governance officer as well at the WHO at the organizational level. So we do pay attention to data privacy, but again, for at least in my own analysis or my own work, a lot of data is at the aggregate level. I think that's true for GBD as well.
Okay, let's come back to the audience. Who would like to ask a question? Yes, please. Ritu. Hi, Ritu Susanna, right in the middle.
Yes, hi, thanks, Richard. I'm Ritu Sadana, and I'm working at WHO. I'm leading our work on aging and health, and also have supported our efforts for the Council on the Economics of Health for All. Terrific discussion. I want to come back to some of the results. I think the issue on identifying the top 10 risk factors as we look to the future in terms of the scenarios or the projections for the future are really important to help guide additional thinking and action. Clearly, we need to have new interventions for those areas, and also put in practice existing interventions. And so my question is that how are you planning to ensure that sectors outside of health are aware of the results? So for example, air pollution, it's not led by the health sector. So this whole of government approach. We also need much more detailed, disaggregated information that's population representative on older adults in all countries. I think that there is some work that WHO has been trying to do, particularly with national statistics offices, but more can be done given what Emanuela described. And finally, just a very small question on, I saw that on one hand, India had a lot of data compared to some of the other countries, but it's not included right now in the subnational data. It wasn't one of the 21 countries. And just wondering, given we had some earlier discussion on India, if that's planned. Thanks.
Thanks, Ritu. Let's take one more question, please. Gentleman just there in the blue jacket.
Thank you so much. I'm Rahim Azami from WHO again. I downloaded the report last week. Thank you so much. I can't even imagine how much work you have put into this. But we are in mid-2024, and this is the global burden of disease for 2021. You got the rest. Thank you.
Okay. Speed up, Em. Come on, what are you doing? You're sitting there in the University of Washington in Seattle, twiddling your thumbs and pressing computer buttons, and you're 3 years out of date. So why? Account for yourself.
Fair point. We're playing catch up. We're fully aware that the definition of timely is not publishing 2021 in the year 2024. We are in a very rapid round of catch up. So we are hoping to release GBD 2023 this December, so 2024, and then the next iteration, GBD 2024, next November. So hopefully within a year and a half, we'll have 2 more releases and we'll be up to date. I have to say that the impact of COVID-19 on our machinery was unexpected and really hard to deal. It drove Haidong to move from IHME to WHO. It was so hard. All joking aside, point very well taken. We're doing our best to catch up. I think there's a lot of good reason to think that we will be caught up soon. If I may answer Ritu's question on India, that must have been a mistake on the slide. We do produce subnational estimates at the state level, and then within each state by urban and rural areas in India. And actually 2 of the fellows that were working with us will be producing district level estimates of BMI in India. Linking to your comment on risk factors, BMI is one of the ones that I am most concerned about. It affects all age groups. We're seeing increasing rates in older adults, but also a lot of rapid rates of increase in adolescents. And I think if we put the financing on NCD risk factors next to it, it would paint a very bleak picture. So I am very much hoping that by linking data on money, which represents in many ways societal investment outside of the health sector, and linking interventions, we could do something to reverse some of the trends for NCDs. I think if you look at what's coming to health systems and where health information systems have the biggest gaps, you're spot on. Above age 50, there's very low data being collected. If I show you the data map by age group, once you get to age 50, 55, we drop off a cliff. At the same time, populations are living longer and experiencing a lot more disabling conditions. And I think this is me venturing, I guess, into your field, but I don't think we have much of an idea of how much health systems are spending on older adults or conditions that affect older adults. So I do think this is a great opportunity to change that because it does impact all countries in the world. And we're already there. The need is already there. And it could have, it could be the new global fund. I remember being in Geneva when the Global Fund got created along with the buzz that was around the millennium. And if we could create a similar buzz now around the upcoming health challenges and create new financing mechanisms, new accountability mechanisms, we could make a big impact. I do agree with you. The Global Fund had a transformational impact. And I think we could do it again.
Calypso Haidong, how do we promote health data beyond the health sector?
So, if I may, the one first thing about the 2021 issue, I think that's just one part of the reality anyone in the global health estimation arena is dealing with. You know, the GBD 2021 has a reference year of 2021. Our World Health Statistics Report recently published has a reference year of 2021 as well. Part of it is just data availability. If you look at all the key health indicators for the most recent 3-5 years, many of the countries do not have any empirical information at all. So in the end, you know, it's a choice between, are we going to just forecast all the way to the calendar year, or have a difference between the reference year, which is your last year with estimates, and the calendar year, and integrate that with long-term forecast as well. So it's going to be estimation, quote unquote, nowcast, and forecast. And, you know, this is also some area, you know, our two departments had overlapping work. For example, you know, our recent Universal Health Coverage Global Monitoring Report 2023, only about 140 countries out of 194 member states has any information in the past 5 years on both health financing and universal health coverage. So this is also coming back to the earlier question you have, you know, health information system or strengthening health information system at both the national level and subnational level is the key. Model is great, but it can also just do that much. It has to make use of available information out there.
And on the intersectoral work?
Yes, so just one example, you know, recently we're working with UAE and Saudi Arabia. What we found out is to actually make better estimates of mortality, you actually need to work with other agencies, and in this case, specifically the General Authority of Statistics in Saudi Arabia and the, you know, the National Agency for National Competitiveness. So we actually need the better estimates or better empirical information on migration, on population, and on vital statistics to piece everything together. And like GBD is doing, you know, triangulation between incidence and mortality and the prevalence. It's always the case for better estimates to use different data sources to have better estimates. So in that case, we definitely need to take the whole government approach and work with every agency that is relevant to our work.
Calypso, you must have a similar issue, don't you, at the Global Fund? There are risk factors and data which are applicable beyond the health sector that you need to get to.
Absolutely. I mean, especially, well, all three conditions, but if you take HIV as an example, and I think in that sense, UNAIDS has done a good job, not necessarily in institutionalizing NASAs, which are sort of the NHAs for HIV, but in showing the way in terms of cross-sectoral. So that what they record, what they try to capture is expenditures across sectors, not just looking at health, because there's so many social and commercial and other determinants that are linked to HIV. So yeah, I think it's critical, and having the conversation with ministries of finance ultimately, and involving IFIs, multilateral development banks, who seem to be interested now in climate, co-benefits, health, and they have an entry point with ministries of finance way better than we do. But yes, having that conversation at that level, I think is really important.
So just picking up on risk factors, when I last crossed paths with Richard Pito, who many of you will know, one of the world's greatest epidemiologists and trialists, made such important contributions to healthcare. He always comes across and says the most wonderful things about the GBD. Can't praise it enough, except for one area, and that's the risk factor area. And there he gets immensely passionate about the fact that we should be much more critical of the risk factor area. And I'm never quite sure why. I think he doesn't believe some of the numbers. And also, I think he has problems with the fact that as you showed in your slide, you have this league table of risks, malnutrition at the top. But there are other risk factors that don't make it into the table. AMR, climate, conflict that we just talked about, emerging infectious diseases. So if we're thinking about how we project these papers to make useful guidance for countries, that table has got a lot of missing elements, and it can't be comprehensive. So I think this is where Richard's skepticism comes from. Do you recognize that critique? Or how would you answer if Richard was in the front row lobbing those questions at you? How would you answer him?
I have answered them. I have been on the receiving end of Richard. He has a point. There are two parts of the GBD. The disease part is comprehensive. We count everyone who dies and gets sick. The risk factor part has an opportunistic element to it. You're right, we don't explore all risk factors. We explore the ones that traditionally have been highlighted in global health and that we have funding to study. On the specific one of tobacco that Richard has an axe to grind with me, because that's my area of work, I will just say that we disagree. I think our measurement of tobacco is really well done. We collaborate very well with WHO on that. And I think we agree to disagree with Richard. We keep improving, we change things. I would say that there's a lot of interest to include new risk factors. On the area of climate change, we have recently added low temperature or exposure to suboptimal temperatures as a risk factor in the GBD. And it's a first step into trying to quantify the impact that that has on health. There are other ones that we're missing that hopefully we'll be able to add. One big step in improving the risk factor estimation that we made in GBD 2021 was embracing this new analytical approach, which we call the burden of proof approach. So if you go to our website under risk factors, you can see a star rating that's kind of like the Amazon ratings or the Netflix ratings that goes from 1 to 5. So if you see a 5-star rating for a risk factor associated with a disease, what that means is that we're fairly certain about that association. There is a causal relationship that we have estimated very accurately. And if you go to the 1-star risk, if you're risk averse, you'll say, okay, I want to incorporate anything that might lead to a worsening of health outcomes, then you include all risk factors. If you want to be conservative, you can say, oh, the 1-star and the 2-star risks, that might change in the next iteration of the GBD as more data become available. So I think that's a step towards being more transparent about some of the limitations that go into the data for risk factors. But it is definitely an area that could be expanded and improved.
Okay, let's come back to the audience for the last round of questions. Yes, please, the woman right on the end there. Hello.
Thank you so much. Meg Davis from University of Warwick and also Global Governance Center at the Graduate Institute. I have a question actually for both Calypso and Emanuela about gender and gender disaggregation. As I remember hearing a few years back, the Global Fund was pushing countries to start reporting data gender disaggregated and that there had been some pushback. And I'm just kind of curious where that is now. Is most data coming back gender disaggregated? And also for Emanuela, whether you're starting to see improvements in terms of gender disaggregation in the data that you're getting or not so much. Thanks.
Thank you. And there's a gentleman right in the middle here.
Hi, I'm Brad Herbig from the Geneva Health Institute. I had a question about related to forecasting and interventions and how we should think about the impact of what the status quo is going forward. So are we maintaining kind of the same level of investment scaling of current interventions versus are we assuming some interventions are going to continue to increase if they have been increasing in the past, and how we should think about the impact on using the current forecasts to say, all right, we need to impact more, or this is what it would take to maintain the current estimates.
Okay, let's come to, thank you, let's come to gender disaggregation. Calypso and...
It's still a conversation that's being had. I think that the data we're getting back or collecting proactively on outcomes are very much disaggregated. But again, when it comes to the design of the grant stage and the types of intervention and trying to understand who benefits from the interventions, the financing flows, et cetera, that's less clear. But it's something that the board of the Global Fund is very keen on, and the Secretariat is responding, I think. So I would say that things are improving.
This is one of the areas I work on, so I will try to be brief. I would say, so across the GBD, a lot of the data we rely on come from vital statistics, and so they get reported for males and females separately. If you're actually interested in data on gender, I would say we have close to none. We have sex disaggregated data for a lot of the mortality indicators. During COVID, it was shocking to me to see, even though the data at the point of data collection are disaggregated, how much aggregation happens when there's a rush to report and such an urgency put behind reporting. So a lot of the data, even now that we get that relate to the pandemic, are not even sex disaggregated. So I think there's a lot of efforts happening on the ground, and there's a lot of room for improvement as well. And if we wanted to move beyond binary men and women, I would say that we're in the infancy stages of data on other genders.
Thank you.
So if I may, I know the question is not directed at me, but I thought you might want to know, what WHO is doing. So WHO is part of what we call the UN SWAP, which is the effort through the UN agencies to promote disaggregation of data and estimates by gender. I think, WHO has been rated on track to achieve that goal. And specifically for the general program Work 14, which we're working on for 2025, 2028, there is a specific outcome indicator on gender worked through health. Basically, we're using a composite index to look at the gender differentials in mortality and morbidity as an overall metric to assess how the gender difference in health is as a way to track the progress made in the future as well.
So we got some discussion about the use of the words gender and sex here. What about the issue of the impact of the status quo?
For forecasting. So there's a lot of discussion around what business as usual scenario is in forecasting. The way that we approach it, and be happy to discuss with you afterwards in more detail, is that we're going to take most recent past performance and use that to generate what might be business as usual in the future. So, of course, for the forecast right now, we took away the impact of COVID-19 because that was a big shock. But what we have seen over the years, and I showed a lot of graphs, health indicators tend to be smooth over time. And so we would anticipate that in the absence of a transformational innovation, such as we saw with ARTs around the millennium, we would see similar pace of progress, and that's what we do in their business as usual. It is, of course, very interesting to model what if there was a technological innovation or some other kind of innovation that would lead to accelerated progress. But for the business as usual, the graphs, when you go back to 1950, kind of show smooth progress, and so we tend to follow that.
Okay, before I hand over to Siri Moon for some final remarks, I'm going to give each of you the opportunity just to say a few words to one final question. I mentioned in my introductory comments that there's this rather thoughtful philosophical phrase on page 2148, if you're interested, of the Dahlia's Healthy Life Expectancy paper, and I'll just read it. As the pandemic recedes and COVID-19 becomes an endemic disease, a new global health landscape is becoming visible. And that really is a provocative sentence to think about, well, what is this new global health landscape? Especially since we're thinking now about what comes after 2030, the end of the Sustainable Development Goals, what will follow the SDGs. So, in a few words, what is this new global health landscape that is evolving, becoming visible, and that should shape the next 15 to 20 years? Calypso, Haidong, we start with you.
I wish you had warned me about this question. I would say from my perspective, this evolving health, I tend to be an optimist. So the evolving health landscape is one where a lot more emphasis and attention is placed on health. Like we saw in the last few years, people value health over anything else. I think the global community demonstrated that very visibly. And so I think the new global health landscape that we can create is one where health continues to be valued as the most important component of well-being, and we take care of our populations globally, regardless of their age, where they live, where they're from, what they do.
Very good, Calypso.
Well, I didn't write this. I don't know who wrote it. Well, to follow on from what you said, Manuela, I guess I think in global health, perhaps in other places as well, form drives function. So then, to get to where your optimist mind is taking us, maybe what we need is a change in the structures, a change in the architecture. I think there's a lot of discussion about architecture, but I do think we need to change the way things are hardwired in order to get a different result. And I think that would be the tough part to get us there.
Very good. Let's start thinking about that now. Hi, Dong.
I think to understand the future, or what this new landscape is, we need to remind ourselves how fragile any gain in population health is. For example, just in 2 years during the pandemic, we lost a decade of progress made in improving life expectancy back to the 2012 level. So that means we need to have better health information system, and we need to sustain the investment in population health at both the country level, subnational level, and the global level. Otherwise, even before the pandemic, we're not on track to achieve any of those SDG goals. And if we don't redouble the effort, we're never going to achieve any of those goals by 2030.
Please give our panel a round of applause and welcome Suri Moon.
Hello, everyone. Thank you again to everyone for having joined us today online and here in the room. I'm going to offer just a few sort of takeaway themes, at least the takeaways for me, to try to wrap up and tie some of these strings together. First, I really want to congratulate the team at IHME and also at the Lancet. This is indeed a tremendous amount of work. I have had the dubious pleasure of having been peer-reviewed in the Lancet for much fewer pages than this, and I really have to ask if this breaks a record for weight and number of pages of a printed issue of the Lancet ever, but really, really tremendous amount of work. And a huge value, I think, to the global health community. And I think one of my takeaways is that there's actually a ton of good news here. Perhaps I'm in an optimistic mood today, contrary to normal, but really, really a fantastic good news story in many ways. And if I could flag for me, what are two big concerns, however, that come out of this? It's really about the demographic decrease, the huge implications of the aging of societies that we really have not yet begun to wrestle with in a serious way in the global health community, at least. And the second thing is, of course, the impacts of COVID-19, and I'm sure the 2022, 23, and 23 studies will reveal even more, actually, concerning insights about the real magnitude of the impacts of COVID-19. Some of you may be wondering, you may be familiar with the Global Health Center. We focus in our work on power, politics, and governance, and it might not immediately be obvious. I think certainly in the discussion, thanks to a moderator who's very interested in politics and governance, we really drew on some of those implications. What does a global burden of disease study, how does that relate indeed to concerns about power, politics, and governance? And for me, there's really two important links. And this is, and indeed it came out in the discussion. I think there's much, much more we could discuss about this. But first is, what do these studies suggest about the priorities that should be at the top of the agenda for global health? How well are those priorities matched by the architecture? How well do we link evidence to policy? And are we ready to, in fact, adapt as part of this new global health landscape that we are trying to begin to imagine? Do we need a global fund for aging? I might ask Calypso. Do we need a new WHO program on romance and childcare and trying to encourage more babies in the world? I have no idea, but we'll leave that for the Assembly to debate this week. But I do wonder if, to me, what's quite striking is what we saw and the way the architecture looks today is very, very different. And I think there's a lot of reflection that has begun already with the Future of Global Health initiatives, but really, I think, the tip of the iceberg, and with funding crises and lack of political attention, or dropping political attention, I would say, to health in the last 2 years. It's a big question. How can we evolve, indeed, to get ahead of some of the trends and projections for where health is really moving? The second big angle, I think, for me, is indeed about accountability. It's about the importance and the value of independent academic research, to provide alternative estimates sometimes to government estimates, to pose questions, to create space, indeed, for questioning authority, indeed, in a particularly post-truth era where more and more information is unreliable, and in authoritarian governments, which are indeed increasing in the world. We are in an era of democratic backsliding, that's for sure. Authoritative, at least as unbiased as we can try to make it, sources of information are increasingly important. And you mentioned India and the COVID death toll. I think China, I've not yet seen a very clear picture of what the death toll from COVID-19 has been in China over the last couple of years. Very curious to see what your outputs will be. So I just wanted to flag, and again, what are some of the implications of these findings for the broader issues on the agenda, not only in this year's Health Assembly, but in the assemblies in the years to come. With that, let me come to our closing of our event. I really want to thank all of you online and in the room for your participation on behalf of the Center and on behalf of our co-organizers, IHME. We will have many future conversations about global health and governance, including tomorrow. We have an event on One Health and pandemic prevention in practice as the Global South leading innovation. That happens at the same time right next door. And on Wednesday, we will have a discussion that focuses very much on global health initiatives and the financing cliff called Replenish or Perish, I believe. You can stay informed about all of these things on our Global Health platform website, and if you sign up for our newsletter, there is a recording of this event that will be made available online very shortly. Let me finally thank our team here at the Graduate Institute and the Center for making all of this possible. Ellen Roskem, Bettina Zago, sitting in the back, Erica Scheinerberger, Thomas Miroshevich, and over there, thank you very much, Moin Hossein Alipur, all of our colleagues at the Global Health Center, as well as here at the Graduate Institute, our IT teams, our communication and events teams. Thank you, and we hope to see you tomorrow or Wednesday.